inflammatory pleuritis, seen best here on this CT scan, mediastinal windows, where you can see thickening and pleural effusion on the right side as well as some on the left side. This is a chart that summarizes how the different connective tissue disorders have their pulmonary manifestations, and really all that we really need to see is that each connective tissue disorder has a different predilection. Scleroderma, for example, tends more to have an interstitial lung disease and a pulmonary hypertension predominance, whilst lupus tends to have more of an alveolar hemorrhage and a pleural disease as well as a respiratory muscle weakness predominance. I'd like to present some illustrative cases that make some of the points and add a little bit about prognosis. This is a 53-year-old woman who was seropositive for rheumatoid arthritis, who had a painful lump excised from her Achilles tendon 6 years ago. She also complained of cough, which was productive of clear sputum, and had a spirometry that showed an obstructive impairment. This is her chest x-ray, and you can see the arrow points to a rheumatoid nodule located in the right upper lobe. This is the associated CT scan that also shows you a peripheral nodule present in the right lung. So the differential diagnosis in a person like this could be that this could be an infectious nodule, and Bushra has spoken a little bit about infections. There are certainly things like fungus, histo and coccidio, as well as cryptococcus, and Mycobacterium avium are considerations. A neoplastic nodule, you will remember that people with rheumatoid arthritis have a higher risk of bronchogenic COs as well as lymphoma because of the immune mechanism problems. So this could be a neoplastic nodule, this could be a straight-out rheumatoid nodule, and this could be an amyloid deposition. Now, people with rheumatoid arthritis tend to have more of the type AA amyloidosis, which is not associated with known nodules, but certainly that's on the differential. We biopsied this nodule, and this is a slide where you can see that there is central necrosis and very little inflammation. So this was a rheumatoid nodule. This person also had the cough and the obstructive impairment on her spirometry, and this is her CT scan, which shows areas of mosaic attenuation. See, there are some areas that are darker and some areas that are lighter. There are areas that are air-trapped. And this is a characteristic presentation of bronchiolitis obliterans, which is a follicular bronchiolitis seen in rheumatoid arthritis, more in women who are seropositive, and it does not respond to bronchodilators. My second presentation is actually similar to somebody that I was managing all of last night and early this morning. This is a young woman who came to our ICU with severe dyspnea, hemoptysis, and acute respiratory failure that ended up on the ventilator. She had a past history of lupus. She'd been on some immune suppressives. You've got them up there. When she came in, her ANA titer was very high, her anti-double-stranded DNA was very high, her C3 and her C4 values, you can see, were suppressed, and the normal values were given in the parentheses. This is her chest x-ray. You can see she's got bilateral alveolar infiltrates, and in her CT scan, you can see that there are air bronchograms. We did a bronchoscopy and a sequential lavage, and she had alveolar hemorrhage. We ruled out any infectious cause on our bronchoalveolar lavage cultures, and we treated her with pulse steroids and cyclophosphamide, as well as plasma exchange, and prophylactic antibiotics and antifungals. And she got better. She improved over a period of 8 days, was extubated and discharged home on a regimen of prednisone and cyclosporin, and is doing very well. I think Asim, perhaps you were involved in her care. Okay. So many patients, right? This is a 54-year-old lady who came in because of respiratory failure, vasodilatory shock, and a cavitary lesion. She had severe metabolic and respiratory acidosis. We had to give her vasopressors, Bicarb. She had recurrent episodes of PET, and all resuscitation efforts failed, and she was pronounced dead 8 hours after arrival in the ER. She had a past history of rheumatoid arthritis that had been poorly controlled, and I'm just going to summarize this slide for lack of time. Initially, she'd been on non-steroidals, then she'd been on methotrexate and sulfasalazine, and then they hadn't worked. She'd been put on an anti-TNF agent, infliximab, after which she was fabulously improved. 3 months prior to admission to the hospital, she'd been to see her routine rheumatologist, and she was doing very well. This is her chest X-ray when she came to the ER that morning, and you can see that she's got a large cavitary infiltrate on the right side. So what caused this cavitary process? Well, we know that people who have rheumatoid arthritis can develop rheumatoid nodules. These rheumatoid nodules can cavitate and occasionally lead to bronchopleural fistulas, and they seem to do this sometimes if they have an associated pneumoconiosis that's called Kaplan syndrome. However, there's also risk of malignancy, as I've mentioned in the past, and there's a twofold increased risk of bacterial infections, as Bushra mentioned. The problem occurs when we look at TNF modulation. We know that this is a cytokine that's important for all kinds of inflammatory responses, and suppressing TNF, though excellent for modifying the course of disease, has led to problems with infections. Pneumococcal infections specifically, but also tuberculosis. And we know that this can happen usually as a reactivation, usually within the first 12 weeks of therapy, and the risk is 4 times greater than that of people who do not have rheumatoid arthritis. This is a representative specimen from our patient, and you can see that she's got acid-fast bacilli. So this lady developed tuberculosis because of the infliximab therapy. So what's the message? We have to have a message at the end of each talk. My message to you is listen to the line of each time. Pulmonary disease occurs frequently. It can occur as the first manifestation of disease. It occurs both due to the connective tissue disease itself or as a complication of therapy. And if interstitial lung disease or another parenchymal process is suspected, get pulmonary function tests and an HRCT, since they are the most sensitive tests that you can order. Thank you very much.